Hello. Hi, thank you very much, Doctors Braga, Herndon, and Canning, and what a beautiful tribute that was to our good friend, Dr. Snyder. I'm gonna share my screen here. It's a real honor for me to have such a great group today on this panel discussion with bladder exstrophy and is volitional voiding a realistic goal for our patients. I'm going to have a couple introductory slides and then I'll turn it over to our panel after I introduce them. So really, what is continence? The word continence comes from the Latin word continentia, which means holding back. And as we all know from taking our board exams and studying about this for many, many years, it's a very complex, coordinated set of activities involving nerves and muscles that really must act in unison. And when this doesn't happen in unison, we get a lot of issues, obviously, with these patients. And I think the initial impetus behind this panel, and again, I want to thank Dr. Braga for thinking about this because I think it'll yield some good discussion, was a series of papers written in the last year over the probability of bladder augmentation, the rates of dryness in these patients, and whether these large studies really shed some new light into what we're actually seeing. So this was a paper that we published with our Pediatric Urology Midwest Alliance group, which showed that the majority of adults at some point are going to be diverted, and most of them are performing intermittent catheterization. And so I find these two quotes really interesting and really telling as to how this has changed over time. This is a quote from Dr. Mitchell in 2005, which says, "We believe that the need to catheterize, divert, or augment a patient with exstrophy should be considered a failure of the initial treatment, and voiding with continence should be the anticipated norm. Most exstrophy patients should anticipate normal voiding with few operations and have little regard for their condition at birth." And recently, in an editorial to Dr. DiCarlo's paper, Dr. Rama Yayanthi and I wrote, "The vast majority of patients with classic bladder exstrophy will not have normal voiding through the urethra, will require multiple major operations to achieve dryness, and most likely will need lifelong intermittent catheterization." So which one of those following is correct? And I'm hoping our illustrious panel would shed some light into this. Dr. Peter Kukow from the Great Ormond Street Hospital in London will talk about the Kelly procedure. Dr. Paul McGrarian from Seattle Children's about long-term outcomes from the Seattle group in the CPRE cohort. Dr. Heather DiCarlo from Johns Hopkins regarding the Johns Hopkins experience and the recent publication this year by Maroof et al. Dr. Douglas Canning from the Children's Hospital of Philadelphia, talking about the MIVEC consortium and the surgery in a consortium translate into better results. And to wrap it up, Dr. Fuchs from Nationwide Children's, speaking about her experience as a younger staff and her perspectives on the importance of mentorship in these complex cases. And with that, what I would like to do is bring up a initial polling question for our group. Please keep in mind, there's a little bit of a delay from our publishing this and you seeing it. So hopefully here shortly, we'll be able to pull that up and you will be able to vote. So the question is urinary continence, meaning volitional voiding and volitional storage of urine with dryness possible in bladder exstrophy? So is the answer A, greater than 50% of patients, B, less than 50% of patients, D, less than 25% patients, or E, rarely? So I will take a little moment to let that poll turn up. And hopefully we'll have some of those answers here published and that will help us with our discussion shortly. And again, I think this is an amazing feat of technology that we can do this. I'm like in complete and total awe. All right, with that, I'm going to stop sharing my screen here. I'm going to turn it over to Dr. Kukow, and I think you'll be able to see the results of that poll, hopefully on your version of the live stream. I turn it over to you, Peter.
Hi, everyone. I feel a little bit like I do when I'm skiing here. It's fantastic fun. It's a real thrill, but at any moment it could go very badly wrong. So thank you for coming. It's a fantastic honor to be part of this meeting. I was very excited by Lewis's invitation last year that I could come, and I was really looking forward to going to one of your greatest cities and having a good time with all of you. And I was disappointed, but clearly other things overtook us, didn't they? I'm very privileged to be the only Brit in the group. I'm very proud of that. So I'm sorry if that comes over that way. I'm very proud to be talking about the work that I've been doing for the last 20 years. And I suppose the easy answer to this is yes. But you do want me to speak, so I better say something else. I'd like to acknowledge the team, my registrars, residents in red, my close colleagues, particularly Divyesh and Navroop and Yazan in Denmark, who continue to collaborate with laboratories in London, and my current research registrar supervised by Professor Christopher Fry in Bristol. And then, of course, our nurses, of which there's many, many more. So apologies if I've missed anyone out. I've always been a bit confused about the definition of voiding, because actually I'm slightly of the opinion that normal continence is what I do. It's a little bit arrogant, but we can all relate to that. These terms of volitional voiding, social continence, dryness, controlled obstruction, catheterization, calibration, reconstruction, all of these things maybe are malleable to enable us to make a good impression from our results from bladder exstrophy. But I think we have to compare ourselves to the absolute norm, which is available to us. And that's what I understand continence to be. And the little guy has got some form of normality, but he's a bladder exstrophy patient, historically part of this group of 86 patients reviewed by colleagues, showing that actually almost all of them were augmented, and that everyone but 2 of them was catheterizing in our early study of the modern stage repair back in the 70s, 80s, and 90s. But I had an opportunity in 1998 when Justin Kelly joined us for a few months to learn his anatomical reconstruction. His principle was that if you did that, you could restore some form of normal physiology. And that was augmented by the decision in the United Kingdom to centralize bladder exstrophy care to our center and Manchester Children's Hospital, which brought us a good number of patients to treat. And the Kelly operation, as I've always done it, is a secondary operation 12 months after the neonatal bladder exstrophy closure, which actually, by the way, does not involve osteotomies at Great Ormond Street, but let's not talk about that. Let's talk about the full mobilization of the soft tissues off the bone, which the Kelly operation is, which includes the urethra, penile corpora, pelvic floor, prostatic area of the bladder outlet, and its reconstruction in an anatomical way to restore its function, the bladder outlet, the urethra, the sphincter, and the penis. And here's the diagrams of what is a pretty big operation, and I still find it scary. I've done more than 200, but it's an operation to be respected. It's not for everybody, but it works. And I was asked rather mischievously, I think, to talk about the penile outcome, which would really distract from the absolute message that no one wants to talk about, and that is the attainment of continence. So look, these are some pictures of a typical penis, the enhanced length achieved immediately after the Kelly operation, and then the urethral construction as if it were a hypospadias repair, and the results have been good. I've got kids using this in the other way, shall we say now, 10, 15, 20 years out from their Kelly operation. We also need to talk about renal complications, but there haven't been many, just a few. But there's no time for that. Let's just talk about continence. Continence is the thing you least like to talk about. People like talking about the procedure that they do. They like talking about this technique, that technique, the other technique, and it just avoids the discussion of the real issue for bladder exstrophy patients, and that is continence. So the attainment of normal continence is possible after a Kelly operation. We decided to assess it in a very usable way that patients and their families could relate to. So this is our assessment score, normally performed independently by our nurse specialists or ancillary staff, or reported to us by the families. I'm going to tell you about 91 consecutive patients, which are a cohort which I began without any exclusions back in 1999. And you can see here that these 2 bladders, one might expect to have a different outcome, but they both had the Kelly operation. There was no exceptions. There was no requirements to attain any kind of capacity or have any kind of bladder physiological parameters before they all had this operation. You can see the split is about the same as we normally see. Now, of course, the attainment of continence generically, it requires a little bit of outlet resistance, coupled with capacity and compliance of a bladder, which then, of course, is able to empty completely. And factored into this whole equation is the urine production. If we look at the capacity and compliance against the first few patients in the first 5 years that had a Kelly operation, we can see the levels of continence. If they have a low capacity, then the continence is 0. But as the capacity creeps up to 50% of what we would expect them to have for age, we transition into daytime continence level 2. And as the bladder capacity increases further, they're enabled to be dry at night. And this was the exciting first 30 or so patients that we looked at, and we found that actually most of them had a dry interval, and surprisingly large numbers were continent in the daytime. And most of those, therefore, that we operated on were continent by school age. Nighttime continence took a bit longer. If we look at the physiology, or rather the anatomy and function, this is a typical urethroskopy. Now, this kid's had a skin-lined urethra, which I've made, but we're going up through past the veru here, and we're coming up to the bladder. Now, I just want you to remember what you normally see when you do a cystoscopy. And that's it. No narrowing, no stricturing. That's what you see. And we've taken this further at Great Ormond Street by subjecting all our patients to video urodynamics. Note the absence of any abdominal wall contractions. And our video, sorry about the software, but I'm a bit of a cheapskate. I'm a Brit after all. But it shows the interesting angle of the bladder outlet and the proximal urethra, which is characteristic of bladder exstrophy. Everything's near the front, but look at the bladder neck relaxing, emptying completely before the voiding cycle starts again. This patient's completely dry day and night. No question about it, he's there. I speak to him every now and again, but he's not the only one. Now, let's think about the physiological considerations, because we wanted to understand what we were doing, how we were achieving this. We did bladder muscle strips on patients before their neonatal exstrophy closure at the time of their Kelly operation and compared them to normative controls. In the organ bath, muscle strips work significantly less contractile with their nerve and muscle mediated responses in the neonatal group. But when we got to the Kelly operation, you can see how that improved dramatically towards the normal value. And I think this emphasizes the benefit of a primary closure because you restore a little bit of the physiology. This is further supported by a single cell preparation that shows bladder exstrophy muscle cells are normal, no difference, as well as cloacal exstrophy, actually, interestingly. And we look at the matrix and we can see the elastic work done in these tissues is significantly greater in the neonatal exstrophy, but returns towards normal at the time of Kelly operation. Of course, the histological slides really do show that. So look, this is the cohort for normal continence. No devices, no catheters, no help, no artificial aids, no clever tricks. We just go to the toilet. At 10 years, male cases, 81% dry, half of them, more than half now, dry at night. 13% of them augmented. Female cases, a smaller group. 2/3 of them dry in the day, half of which are also dry at night, and 1/3 of them augmented, but it's a smaller group. That number's changed now out to 15 years. And then salvage cases, patients who'd had a different procedure, maybe a bladder neck procedure or something else, actually did pretty well too. And I've seen the physiology, I've seen the dryness, I've met the kids. They are there in London, in the UK, and around the world as well from my cohort. So look, the summary of this. It's very clear that the lesion of bladder exstrophy is anatomical derangement, absolutely, but also some bladder fibrosis, which we can address in the way that I've proposed. The continence for these patients actually evolves after the Kelly operation, but a dry interval is established very early on, and as bladder capacity increases, they transition the continence levels. Physiological parameters, I hope I've demonstrated, are restored, and we actively have a program of video urodynamics for all these patients. Up to 80% of patients become normally continent in the daytime. So what? We're having this conversation. We're all in a row. We've lined up the ducks. We're all going to say what we feel about our procedure. But what's different from every other meeting that we've been to, where everybody puts their thing in the thing, we'd have no time for discussion, so I'm going to stop in a moment, and we make no conclusions. Are we prepared to change? If I hear something better today, I'm going to change. But other people might need to consider that. And can we, as a result of that change, make progress together with this needy group of patients? Because I'm not satisfied that I haven't got 100%. Thank you very much. I'm going to hand over to Paul now. Thank you.
Dr. McGuirean, you're muted.
It's an honor to be here today. I do not have any disclosures, but will disclose that both Dr. Canning and I will likely share the same views on the topic of continence and bladder exstrophy. This is a patient that I saw last week. He is an 8-year-old male who had a complete primary repair of bladder exstrophy. He comes to the clinic, he reports that he's dry in the morning when he wakes up. His voiding volumes in the morning are around 150 mLs. He does have daytime stress urinary incontinence, and he's continent if he voids every 1 hour. So what would the management of this 8-year-old be? Should we subject him to a bladder neck reconstruction with or without mitrofanol? A bladder neck reconstruction with an augmentation because his bladder exstrophy his bladder capacity is half of what it's supposed to be? Or should we close his bladder neck and make him completely dry? Or just wait? And I think when we look at our experience over time, things have changed. I think we all know that the goals of management include urinary incontinence, functional genitalia, and satisfactory cosmetic outcomes without compromising renal function. And I think I'd like to stress renal function, make sure that renal function is not compromised. I can also state that the way I close bladder exstrophy today is different than when I trained 30 years ago. The improvements made are a result of the collaboratives such as MyBEC, the US-India Collaborative, PUMA, that have resulted in a better and more successful closure and hopefully better continence and cosmetic appearance. Cosmetic results like the one shown on this slide are achievable, and this is not a Kelly procedure, that's CPRE. You actually get good penile size. The child has near normal appearance of the phallus due to external rotation of the corpora at time of closure and creating a hypospadiac meatus. The skin also is reconfigured to prevent dorsal suture lines, and the inner prepuce is rotated ventrally to be used for the urethroplasty. Improvements that they may affect continence status and potential bladder function include a successful initial repair, positioning the bladder deep in the pelvis, and improved bladder neck funneling, which is different than the Young D's repair. Recent improvements, such as urethral reimplantation at the time of initial closure, may affect bladder growth and function. Creating a hypospadic urethra may also improve bladder function by allowing the bladder to be placed deep in the pelvis. I'd like to start with my summary and state that volitional voiding and continence is achievable, but not in all. Management of this requires patience and avoiding early interventions such as procedures such as bladder augmentation, as the bladders tend to grow over time. We also need to better listen to our patients and their families and have patient-reported outcomes determine areas of research or improvement. So the question that maybe need to be asked is not, is volitional voiding achievable, but how do we support our patients and families so that they have an improved quality of life? Multi-institutional collaboratives with high volumes are imperative to critically assess outcomes and make continuous improvements in the management of this condition. I want to briefly address this article and state that this is an important study and the results are sobering, but that it outlines practice patterns that were prevalent 20 to 25 years ago. Bladder augmentation rates have declined over time, and indications for enterocystoplasty vary, as seen on this graph, with variability of around 30% between institutions. This has already been addressed by Dr. Kokau, and this is a systematic review that was done by Dr. Ruth's group that shows variability in defining continence, with over 1/3 of the articles reviewed not providing a definition. They recommended defining continence as dry, with or without catheterization at 3 hours intervals or more. Volitional voiding, which is the topic of this panel, means voiding per urethra at will, with or without catheterization. Dr. DiCarlo will probably describe this, but when I did the calculations from their experience, we look at patients that are voiding per urethra without catheterization, their rate out of the total cohort is 24%. I'd like to start this discussion of the Seattle experience by mentioning Dr. Julian Ansel, who passed away this past year and was considered the Dr. Jeffs of the West Coast. He reported back in 1979 on 28 stage repairs with a continence rate of 32%, voiding per urethra, but at the expense of at least 5 operations per child. As you all know, the primary repair was popularized by Dr. Michael Mitchell, and Dr. Rich Grady expanded on that experience in Seattle and also started the US-India collaborative with Dr. Shukla from CHOP that has now grown to an international workshop. And it's called the US-India collaborative, but there's also Dr. Pipisali, who's part of that collaborative from Qatar. Both the India collaborative and MyBEC group have made significant improvements in the closure technique that will hopefully result in better outcomes. In 2008, Dr. Shnorovorian from our group reported on the long-term results from our institution. They defined continence as daytime continence of 2 hours or more with volitional voiding, and 17 out of the 23 patients achieved daytime continence for a rate of 74%. 2 out of the 10 boys and 3 out of the 7 girls achieved continence with CPRE alone, another 18% with CPRE and bladder neck injection. We then reevaluated our results with longer-term outcomes and using the recommended definition of volitional voiding with greater than 3 hours intervals. Those on CIC, even if they were dry, were considered incontinent. As you see with CPRE alone, 17% of patients can achieve dryness with volitional voiding, and another 7% with CPRE and bladder neck injection with deflux. Some required a total of 5 injections. The total continence rate was 46%. We do not have the experience with macroplastic as the UK group does. A few important observations I'd like to make from this study: that continence improves with time and improved in teenagers. A few patients gain continence as they reach puberty. Continent patients have larger bladder capacity, and on average, the bladder capacities of the continent patients are around 80% of predicted. This past year, our fellow Dr. Canalicchio studied the female population with bladder exstrophy. Continence, again, here was defined as greater than 3 hours dry intervals with volitional voiding or clean intermittent catheterization. We also used a new definition of partial continence, which includes those with stress, mild stress urinary incontinence, and those with enuresis. Continence was achieved in 33% and partial continence in another 50% of patients. So the total continence and partial continence rate was around 80%. The mean number of procedures required to gain continence was around 3, and the median age at the last continence procedure was close to 10. This diagram breaks down the continence outcomes in those patients that volitionally void versus those that are on CIC. It is important to note that the majority of patients are volitionally voiding. Although only 2 out of the 11 or 18% are continent, the majority have also partial continence, or around 76%, with only 2 that are totally incontinent. 7 out of the 18 are clean intermittent catheterization, and only 4 had bladder augmentation. So our bladder augmentation rate in this group of females is 22%. When you look at those that volitionally void, the bladder capacity was close to 200 mLs, and the majority had coapted bladder next on cystoscopy. In the CIC group, the average capacity was diminished in comparison, and the majority had an open bladder neck. There is limited data on patient-reported outcomes in adults with this condition. This needs to be studied further to determine what is important to this patient population and their families, and more importantly, used to direct future research and exploration. Anthony Schaefer, as part of the SPU task force, conducted a structured interview of patients and families with bladder exstrophy at the most recent ABEC conference in Los Angeles. And as you can see, a large majority of patients and their families desired increased research on continence. What was interesting in those interviews, another survey that we'll be discussing, is that mental health and well-being was of the utmost importance to the community of patients and their families. Dr. Canalicchio from our institution conducted a survey through ABNC of adult women with bladder exstrophy. The mean international consultation incontinence questionnaire, the short form, was 6.2. The overall score ranges from 0 to 21, with greater values indicating increased severity. So as you know, the severity scores were low. The majority of respondents reported never leaking, and most women reported no or small amount of leakage. This chart captures current bladder management. The majority of women require catheterization of a channel or urethra, around 43% through a catheterizable channel, 15% per urethra, but around 20% of the patients void per urethra volitionally on their own. What was also important that women were asked what topics they felt were important to study. Most answers did not center around continence, but they centered around sexual function, body image, mental health, and reproductive outcomes. In conclusion, volitional voiding is achievable in patients undergoing CPRE. Our work underscores the importance of providing mental support and counseling to these patients. Continence may take years to achieve as bladders continue to grow over time. We would recommend patient-reported outcomes to direct research, and close long-term management throughout development and appropriate transition into adulthood is of utmost importance. Thank you. And I will hand this over to Dr. DiCarlo.
Thank you. It is an honor to be here today. I really appreciate the invitation from Dr. Braga and Dr. Gorgoyo, and to be among these wonderful colleagues that I have here to talk a bit about our extrophy continence experience, particularly talking about voided continence, not just catheterizable continence. I have no disclosures. So briefly, we're going to explore the approach to extrophy at Johns Hopkins, and we're going to also look more closely at the continence outcomes, focusing on volitional voiding per urethra, as per a recent study that we published. So a little bit about our division, the Jeffs Division of Pediatric Urology at Johns Hopkins, which I've been an honor to be a part of after my fellowship. As we know, Robert D. Jeffs was the founding chief of pediatric urology here at Johns Hopkins on the Brady. He had done his fellowship at Great Ormond Street, something that we have a connection with Dr. Cacao, and Toronto's Hospital for Sick Children. He was there before coming to Hopkins. This is our current extrophy team at Johns Hopkins. Of course, Dr. Gearhart, my senior extrophy partner, Dr. Sponseller, who's the chief of orthopedic surgery, myself, which it's been an honor to be a part of this, as well as Dr. Eldridge, who's the director of our voiding improvement program, and really an integral part of getting our patients continent and ready for their surgical procedures, not only the ones that are going to be going on to bladder neck reconstruction or have primary continence from their closure, but getting them ready as well for if we're going down the road of augmentation and stoma, et cetera. As well as Dr. Bartolini, who's been a fantastic addition to our group. She's a wonderful child psychologist that specializes in the children with urologic congenital anomalies, and she's a vital part of getting our kids ready for surgery. Additionally, there's also, of course, Dr. Dosimo, Dr. Matthews, and Dr. Lakshmanan, who have contributed to the extrophy team here at Hopkins. So the common goals of extrophy management, irregardless of the approach, our bladder closure, we want to protect the upper tracts. We talk about preserving renal function and minimizing the risk for chronic kidney disease. Having interest in the transitional world, and as we look forward and looking at our outcomes and constantly reevaluating our outcomes, we're looking at this in the future because our children are living longer and longer. We want to make sure that our surgeries are not affecting long-term renal function. We're going to be focusing urinary continence today, and sexual function is, of course, very important. So why is the success of primary paramount? Really, we're looking at a successful primary closure, even though when I talk a little bit later about our studies, we are looking at reclosures as well. We look at gaining adequate bladder capacity sooner, a shorter time between bladder neck reconstruction and dryness, and basically increased bladder capacity so that the child that is voiding can have a quality of life, that they're not having to use the bathroom every 30 minutes. If initial closure fails, we see only 60% get the capacity for BNR. And as you'll see a little bit later on, we're using urodynamics to help us guide the appropriate selection for patients that are going on to bladder neck reconstruction. And only 50% of the above are dry and voiding overall, less than 25%, as you've seen here. So just so briefly about the modern stage repair of extrophy, we were going to talk a little bit about the appropriate timing of primary closure, the focus on tension-free closure, and the judicious use of osteotomies. And then we, at Hopkins, use a 4 to 6 week postoperative immobilization or traction. Again, focusing on renal function, then moving down the road to urinary continence, and then we work on the genitalia. So here's a brief slide, and I will provide these slides for everybody at the end of this on our timing, looking at primary closure, whether or not it's newborn delayed. We're going to evaluate these kids to see if they're appropriate to be closed right away. We also get some referral delay, so patients that come from other institutions, so they come to us a little bit older. We generally will do our upper aspadius repair around 6 to 12 months. And then down the road, we're talking about continence procedure. That's very involved with our voiding improvement program, getting these children ready. We're evaluating them on about a yearly basis, at least, with ultrasounds, making sure that their kidneys are staying safe and their bladders are emptying appropriately. And then they get evaluated as well with our voiding improvement program as we're approaching the age of continence. And it's really a multidisciplinary team approach, which is so important, as we all realize. So the evaluation of the extrophy, of the newborn with extrophy, we're taking a look at the size of the bladder template, the presence of polyps and other anomalies that the child may have. Of course, initially we're removing the umbilical clip and tying the stump with silk. That's one of our first things when a child is born here that we have our residents do. Then we usually will perform an exam under anesthesia where we assess the bladder template, the size, the quality, and the ability to reduce it into the pelvis. And this is the time that we're deciding if the child is suitable for a newborn closure versus a delayed closure if the child needs more time to grow. We get some preoperative imaging, including an ultrasound to see if there's any other anomalies. A KUB will help us determine the diastasis, and we actually do MRIs on our children as well. So just briefly, I'm going to buzz through these slides quickly on our closure. We have the dissection of the bladder template, the dissection of the urogenital diaphragm fibers, and then the closure of the bladder. We're going to use our tubes to drain the bladder, etc. We're going to close our urethra. So there is some elements of tapering of the urethra when we're doing these closures. And we use another layer as basically underneath the pelvis. When we bring the pubis together, we basically bring the medial pressure on the pubic rami, and we use a number 2 nylon suture to get this urethra deep into the pelvis. And of course, in our boys, we're watching to make sure the phallic blood supply is not compromised at all. And of course, if that's the case, if the child doesn't have osteotomies, we will we'll proceed to osteotomies or loosen up the closure. Closure of the abdomen, we can see here, basically straightforward. And then following closure, we maintain these children on antimicrobial prophylaxis because we are not routinely doing reimplants in our modern stage repair and making sure that they don't have pyelonephritis. And we have close evaluation of the upper tracts, as I described earlier. Serial renal ultrasounds, at least on a yearly basis, annual to every other year, cystoscopy and gravity cystogram under anesthesia with urodynamics. And then we plan on epispadias repair in the males around 6 to 12 months of age. Now, in these children that come to us later, if they're a delayed closure and or if they're a reclosure, we will proceed with epispadias repair at the time of closure. Our general technique is the modified Cantwell-Ransley repair, and we give them testosterone preoperatively. So when we're talking about continence procedures, there's a lot of options, as we all know. Our voiding improvement program is really at the cornerstone of helping us determine what's appropriate for each child. It's multidisciplinary. The pediatric psychology and our nursing support is so important. The couple of options we'll talk about briefly are the modified Young D's Ledbetter bladder neck reconstruction. And it's really important that we focus on proper patient selection. And we've become very, very stringent with criteria to make sure we're picking the right people for these patients that undergo these procedures. They need to have an adequate bladder capacity, that their quality of life will be good, that they will be able to hold to go to the and be able to not have to go to the bathroom every 30 minutes. We want favorable urodynamics. We want to see safe pressures. We want to see good emptying. Sometimes we consider a dual procedure. And my outcomes, well, we're going to be looking at the bladder neck reconstruction today. And we, of course, are counseling that these kids might require intermittent catheterization so that, managing expectations with the families are so important. The other options, of course, are augmentation, cystoplasty, urinary diversion, bladder neck transection, etc. These kids also and the families must be motivated to be dry. And that's one of the big things that our voiding improvement program is working with to make sure that we get there. So patient selection, as I said, is critical. Adequate bladder capacity, urodynamic parameters, patient preparation is so important. And really, the multidisciplinary approach is just so important, as my colleagues have mentioned here today as well. So to touch briefly on a recent publication, we have our urinary continence outcomes in classic bladder exstrophy, looking at a long-term perspective. So we drew from our database that's been ongoing since 1975, and this went to 2017. And we were able to parse out 423 classic bladder exstrophy patients, so no variants, no cloacals, et cetera, that had a closure, and as well as we had data on their continence procedures. 71.5% had successful primary closures, and 28.5% were reclosures. Parsing down further, and you can see the diagrams on the right, we had 162 patients, so 37%, had bladder neck reconstructions. And we're just going to talk about that specifically today because we know that augmentation, bladder neck transection, stoma, these patients can have great quality of life with catheterization, but we're talking about volitional voiding here. Our mean follow-up was 7.2 years with at least 3 months. And we define continence as our standard continence dry interval of greater than 3 hours for during the daytime and no nighttime leakage. And these patients are not ones that are doing CIC because we do have a number of patients that undergo bladder neck reconstruction as well as CIC. 91 out of the 142 we had follow-up on, so 64.1%, had bladder neck reconstructions, and 8 out of the 91 were voiding per urethra, and that's 56.3% out of the total 142, okay? 11 out of that 91 had to have CIC, and you can see our demographics on the right here. So volitional voiding per urethra was 80 out of the 350 total that we had long-term follow-up, and that is including all continence procedures. So we're looking at 80 out of the patients that also have had augment stoma that we're not expecting to void per urethra. And that's where this is less than 25% that we had volitional voiding per urethra. You can see a breakdown of our patients here. Now, one more table this is our supplementary table, which is included in the online, is that this is our data from our institution. So you can see here where the patients had their primary closure here, as well as continence procedure. We looked at 52 patients that had bladder neck reconstruction by itself. 38% were continent and 73% continence rate. So that really speaks to just the careful selection of patients when we're counseling, especially, and also, sharing this data with our patients. So in conclusion, voided continence is possible in Exstrophy, but patient selection is critical and really good surgical planning. And we've said that along the way with my colleagues here as well. The multidisciplinary team approach, establishing patient and family expectations is so important. And really long-term follow-up into adulthood is what we need and what we're continuing to do. And this is going to allow us to refresh our data and come up with better outcomes to describe to our families, and really establishment of centers of excellence that are focusing on Exstrophy. Thank you so much for the opportunity to speak today. And I'm going to pass my screen along here.
Can everybody hear me? Can everybody hear me?
Yes, sir, we can.
Okay, great. Well, thank you, Louise. Thank you, Tony. And thank you, Patricio, for asking us to be involved with this great session. I've learned a ton already. So you asked us to talk about what the collaboration and is it better for the baby? Is it better for the surgeon? And do they void? I just want to give you a little bit of background as to how I came to this. Is really Bob Jeffs and John Gerhardt, along with very few others, that got me interested in pediatric urology, and I got the Exstrophy bug working with these two who had then and now the largest series of patients with bladder exstrophy, and a tremendous commitment, a consistent program, a high surgical volume, and tenacity. I never saw them give up on a baby. It was shocking at the tail end of my fellowship when I went over to see Barry O'Donnell, who we recently lost this year, another wonderful man, who had a brand new baby with bladder exstrophy that came in on the day I was leaving, or the day before I was leaving. He leaned over the baby with me and then whispered in my ear, because there was a crowd around us, that he didn't believe a single thing that Bob Jeffs had to say about bladder exstrophy. He fundamentally didn't believe Bob Jeffs' results. And so being I wasn't sure whether I should punch him at that point or but I thought it might have been an international incident. So I went along and went home and asked Dr. Jeffs if I could look, and John, if I could look at their series. And what we found here was that 67% of the patients that had made it through the staged repair, who had either been closed earlier or had an osteotomy, had a better than 3-hour dry interval. These were not 67% of consecutive patients, but those that made it through. And there were, as Heather pointed out, there were a series of hurdles that these patients had to achieve before they were given the right in those days to have a bladder neck reconstruction. Right around that same time at the Great Ormond Street, Jean Hollowell graduated from her fellowship the same year I did, spent another year at the Great Ormond Street, and looked at a relatively small series of patients who'd had leak point pressures done in urodynamics. And only 20% of the patients in her series had normal voiding. And it turned out that in two separate patients, if you read it carefully, that group that had normal voiding had a very gentle leak point pressure, just a little bit of extra tension between 1 and 10 centimeters of water pressure that allowed the bladder to grow and develop normally. And I think this is what Peter was talking about in his talk, and that is the bladder can heal, just like it does in posterior urethral valves in children who have dysplastic kidneys and tiny bladders. With gentle, patient stimulation, the bladders get big and the babies get dry. Now, John Duckett, those of you who knew him, knew that he was almost the opposite of Bob Jeffs in many ways. He was a very impatient guy. And his idea was that he wanted all these babies to be dry by 4 to 5. And that resulted in only a 12% continent rate as defined by voiding with dryness. He could make everybody dry. Howard and John can make virtually everybody dry, but most of the patients were on CIC. And then in 1996, when Christopher Woodhouse looked at D.I. Williams and Philip Ramsey's series with nearly 20-year follow-up of 57 primary classic bladder exstrophies born between 65 and 74, there were 25 that had early diversions, usually U-SIGs in those days and other variations. 32 were reconstructed. They had 13 early successes, and with longer follow-up, only 3 of the 13 ended up voiding volitionally. And for me, when I read between the lines, to me it meant that if you create a controlled stricture, as we were apt to do in those days with the Young-Ledbetter approach, the bladders do well. But there's no organ in the human body that's designed to contract against a fixed stricture, whether it's your aortic valve or the gallbladder ducts. If you have an organ, a hollow viscus, that is trying to contract against an outlet, sooner or later it burns out. And that's what we were seeing in the few patients that we had dry at CHOP. And I think that's probably what has happened to all of us. Philip, at that point, I think had more or less given up on the idea of good voiding and normal voiding with exstrophy. He made this comment in Curitiba, Brazil in 2005 at a meeting, and I was happy to be there with him. And so was Chris Woodhouse, and we sat on a panel on bladder exstrophy. He looked at it into a meeting hall with 2,000 individuals present and challenged them to show him a single male bladder exstrophy patient who voided normally and is dry day and night, who ejaculates, has normal sexual function, and can sit through a feature-length film without wetting. And no one raised their hands. And I think this is what drove us in Indiana and other places to move toward a diversion approach rather than, and also at CHOP at that point, a diversion approach rather than waiting it out to see if these patients could be continent. Well, right around the same time that Chris Woodhouse's and Redgrave's paper came out, Mike Mitchell showed us a video in the first series of patients. And you can see that 12 out of 12 of these babies of males and 6 out of 6 had dry intervals. And John Duckett whispered to me in that meeting, he said that the next exstrophy that comes in, we're going to do it together and we're going to do Mike's operation. That boy voided in the post-op period. He had a little dilation of the ureters at 4 months, but to this day, nearly 24 years later, he's had no other surgery and is dry day and night, normal upper tracts. I had never seen that before. My feeling was then that if we could do that, just the way Mike had, that the Mitchell repair might be transferable. It may allow for more normal voiding, and that the voiding may be persistent, and that we should adopt this approach. Well, John Duckett died suddenly in February of 1997, and we ended up in an interim period between 97 and 2000 with an approach of doing these babies at the end of a busy clinic through the night. And I learned that this was a potentially dangerous operation. We had our only 2 dehiscences in our series. We had 2 glands injuries, which were not severe, fortunately, nothing like what we're seeing in this illustration from a paper that Doug Huesman and John Gerhardt published appropriately in 2004. But this is one of my own patients here, who you can see lost part of his left hemiglans. And being as close as we are to Hopkins and being a loyal Hopkins alumnus, I thought we were sort of out of the business of doing bladder exstrophy repairs unless we could figure this out and make it safe. And so drawing on the experience that I'd had early on at Hopkins with a series of Bob Jeffs, where older patients were doing fine as long as they had osteotomies, we stopped doing the repair in the middle of the night. And we started to delay it. We built a consistent team. At that point, it was Mike Carr, Dave Horn, and we did osteotomies for all, including complete epispadias. And in the ensuing years between 97 and 2013, when we started MyBEC, we had only 36 consecutive patients with bladder exstrophy or epispadias. 25 of them had osteotomies, and we didn't do a single bladder neck reconstruction, and we waited this out. In the group with complete bladder, with classic bladder exstrophy, who had complete repair, we had about 14 of 22 who had potential, meaning that they voided with a dry interval, about 64%. Of the epispadias group, we had 15 of 15 with potential, which to me meant that the bladder neck work, which is I think the critical part of what Mike was doing, that was different, was the test of concept. If patients with epispadias with a good bladder that could achieve continence reasonably quickly, then what we were doing with the bladder neck made sense. The problem was, at 50 years of age, I was doing 1.4 cases a year of classic bladder exstrophy cases. That giant sucking sound that we used to hear 90 miles south of us from Hopkins was gobbling up all of our patients. And these patients were bypassing CHOP. Some of the kids in South Philly were going down to Hopkins. So right around this time, Atul Gawande wrote a piece for the New Yorker, which I thought was great, that talked about hiring or getting a surgical coach, knowing that musicians have coaches, athletes have coaches, writers have editors. Why not us? So over a 2-year period, we cobbled together this group: Joe Borer from Boston, Mike Mitchell as our coach, and John Krieger in Milwaukee. And then we recruited a few other exstrophy surgeons and other people that are committed to bladder exstrophy care, and went to work. The first case in February of 2013, I'll show in a minute to you. We're up to 128 cases now, over just over 7 years, with bladder exstrophy, epispadias, cloacal exstrophies, and a few variants. And these are what the volumes look like through 2020, through part of 2020. So now that we had the volume that seemed to increase as soon as we started to focus on it, are we any better? Well, here's a list of things that I wrote down about the things that I've learned in the past 7 years. The critical things are the fact that we no longer separate the corpora, the glands, and the rest of it really has to do with what we do at the bladder neck. In the past, of course, we would make these the bladder neck reconstruction as long as 3 centimeters in the newborn. Over time, we've continued to tweak this work, and we've used the Pena stimulator to identify the pelvic floor musculature, which helps us distinguish the pubic bands that we take from the functional muscle. And it's this area here, this 1.5 at most centimeter zone that we now call the continence zone, that is adjusted. We start with about a 30 to 35, sometimes as much as 40 millimeter width here that we trim down gently to 20 millimeters at the bladder neck. We define the bladder neck, which is not always that easy to see, as the point halfway between the verumontanum in the male and the introitus in the female and the ureteral orifices. And this is the critical piece. This is what we think makes the difference. And it's interesting to see how Heather has evolved and how Peter Kukow has evolved into similar thoughts. And I think we're coming together. I don't think it's that we're as different as we thought we were when it comes to continence. Is it better for us? For sure. I don't roll around at night the night before a reconstruction for bladder exstrophy worrying about whether I'm going to injure the penis. I know how to close the pubic the pubic symphysis without injuring the glands, because we watch for glands bleeding as we do that. Similar to what Heather was saying. We're more consistent. Continence doesn't come through an operation that we do. We try to make a good anatomical closure without injuring the structures deep in the pelvis, but getting the bladder neck deep without injuring the bladder floor musculature. Continence comes gradually. It's much later than age 5. And bladder exstrophy is a spectrum that we can talk about later, but we believe that with a few metrics, we can actually grade these patients ahead of time, and we can talk about that better. Are we doing better for the child? I don't know.
Can I ask you to wrap it up, please? Sorry.
Thank you. 20% of our pre-MyBEC group is now continent, voiding with a better than 3-hour dry interval with 11-year follow-up. We have about 39% that are voiding with dry intervals. And do they void? Here's a baby of Joe Boers.
This is a patient
4 months
post CPRE,
4 months out of his surgery, and you can see him voiding. Here's the bladder neck reconstruction with the Vero in a good spot, and the bladder neck in a nice spot. And here he is 3 years later, voiding beautifully. Here's a boy of John Krieger's, just to show that Joe's not the only one that can work that kind of management. And here's a baby of Dana's that she just did in November. Here he is voiding on his changing table. It is better for the baby. It's better for the surgeon for sure, because I think what's better for the surgeon is frequently better for the baby. And babies born with classic bladder exstrophy do void. We close them all, and I think if we're patient with them, they all do well. Thank you very much.
All right. Thank you so much for the opportunity to present today. I'm greatly humbled to be on this panel with some of the world's experts on bladder exstrophy. I speak for all the young reconstructive urologists when I say thank you to the giants in the field who have come before us and laid the foundation of bladder exstrophy management. It is in all humility that we accept the challenge to carry on your work. I've tried to objectively analyze the literature about bladder exstrophy. And in doing so, I realized that while our knowledge has increased immensely over the years, there are several major questions that we need to answer, and I hope to highlight these today. This talk will focus largely on questions as opposed to answers, but hopefully it will spark future conversations that will help us find these answers. To state the obvious, bladder exstrophy is one of the most challenging conditions that urologists and families have to deal with. Outcomes are suboptimal even in the best of hands, and patients are understandably frustrated with outcomes, particularly because of continence, penile size, and the need for multiple invasive operations. As we know, the majority of exstrophy literature has been focused on achieving normal urethral voiding and continence. Most report social continence, but what exactly does that mean? Is one person's definition of social continence the same as the next? Even the largest studies report only about 25% continence rates, as we've heard today. This begs an honest answer to the question, is normal urethral continence a reasonable expectation in bladder exstrophy? A natural question for a family of a baby born with classic bladder exstrophy is, will my child be normal? And perhaps we need to be more honest and comfortable with saying no, but that with appropriate bladder management options and proper psychosocial support, the child will have a meaningful and satisfying quality of life. In reconstructive urology, we're all taught an important hierarchy that guides our decisions. We must first preserve life, next we must preserve the kidneys, and finally preserve quality of life, which in this case would include continence and preserving sexual function. We must respect this hierarchy and not sacrifice a higher outcome for a lower one. This leads me to question, are we harming the kidneys in trying to preserve urethral continence, and does bladder closure impact renal function? Data from the MyBet group has shown that after closure, new mild to moderate hydronephrosis was seen in about a third of kids undergoing primary repair, and several girls had obstructive complications. Certainly, continence is important, but with our current techniques and by emphasizing urethral continence, are we harming the kidneys? The answer is we really just don't know, but we need to think about this and consider what we're doing long-term to these kids. Does our quest for urethral continence and performing early bladder neck surgery have a negative impact long-term on the upper tracts? We don't know. The next major gap in the literature is with respect to sexual function. We understand that boys with exstrophy have corporal bodies that are smaller than typical, and when the bladder is mobilized and dropped down into the pelvis and the pubic bones are brought together in the midline, the corporal bodies are also dropped down, making the penis often all but disappear in many cases, particularly with CPRE. This picture is a boy who underwent CPRE at our hospital several years ago, and you can see he has virtually no penis at the end of the operation. So I wonder if we dedicate some focus to trying to improve penile size and sexual functions rather than only focusing so much on continence, could we discover ways to improve penile size? Preliminary data from our multi-institutional exstrophy group, PUMA, has shown that not bringing the pubic bones completely together in the midline may allow for increased penile length. Also, if we accept that urethral continence is unlikely, is there a role for transecting the urethral plate from the bladder neck, performing a bladder neck closure and diversion in order to allow for larger penile size, particularly in certain situations where there's a large pubic diastasis or particularly small glands? This seems very drastic, but what might a patient prefer, maximal penile length or the ever elusive urethral continence? The reality is we really don't know what patients would want. We do what we think is best for them, but perhaps we need to better understand what patients value and involve them in the decision. We need to strive to incorporate the patient's opinion and experience into our research model. Patient-reported outcomes are critical in understanding the long-term effects of the care we provide, and involving patients as stakeholders will help us guide our decision-making. Well, let's not forget about the girls. Discussion often revolves around boys with exstrophy and penile size, but as Dr. McGarrian described, his group from Seattle recently published this study about patient-reported outcomes in females with exstrophy regarding sexual function. So it would seem that we're starting to understand the importance of these questions, but we need to do so much more. So I've discussed several ideas and questions, but how do we do this? How do we train the next generation of bladder exstrophy surgeons? Resident and fellow exposure to exstrophy has gone down for many reasons. We no longer manage exstrophy as an emergency, so closure is often delayed, and many families choose to go to large volume centers. Most institutions see just a few cases of exstrophy a year, if even that. So how do we make sure that the next generation can adequately be trained to care for these kids? I believe we need to improve our exstrophy education model by collaborating between institutions, having honest conversations, such as this panel today, about what we don't know, and we need to focus on mentoring and educating the next generation of exstrophy surgeons. Several multi-institutional groups already exist. We've heard about several of them today, such as our own Midwest Collaborative group, PUMA. PUMA is a great example for what can be done throughout the country. Our mission is to further develop research questions and analyze the current thought processes, honestly and with humility as a group. The foundation of this group is to mentor and educate the younger surgeons, to pass on the experience and knowledge of the senior surgeons. Our senior members have recognized the future of bladder exstrophy lies in the hands of the younger surgeons who have dedicated our careers to reconstructive urology. The onus is on us to answer these questions that I have posed today. I can speak personally from my experience with PUMA that this model allows for an enhanced appreciation and understanding for this complex disease, and the value of the conversations our group has had discussing the nuances of this disease is really impossible to measure. So in summary, I want to thank the organizers again for recognizing the importance of this topic, and I'm honored to share the virtual stage with these experts. The dedication and contribution of the pioneers in our field is astounding, but I propose that in the future, the conversation about exstrophy perhaps could be different. Perhaps we could put less emphasis on urethral continence, which has been proven to be so difficult to achieve, and we should shift our focus to other outcomes. I implore the young exstrophy surgeons to come together and help push the field forward and work towards these answers and continue to help this very challenging patient population. Thank you.
Thank you so much, Dr. Fuchs. That was great. And thank you again to all the panelists. That was absolutely fantastic. I'm going to share my screen here and pose that same question that I posed at the beginning. And again, is anything you have heard today change your mind on this question? And then hopefully we can compare this. I will say that, interestingly, upwards of 60% of the initial respondents answered either D or E. So clearly, we both need to spend a little bit more time with Dr. Kukau in England, which we're not allowed to go to right this second, but maybe later. So just a reminder, if you want to ask any questions, there is a chat dialog box to the right of your screen. You can join as a guest, and you can ask any questions now. I'm reading the questions as they come in, and I'll propose them to the panel. I do want to just start off while the questions are coming in, perhaps. Interestingly, Dr. McGarrian, your sharing of the data from the parental group is really interesting because it looked like only slightly north of 20% of those patients were volitionally voiding, which goes along with the data, the large volume data presented by the Hopkins group and by the PUMA collaborative. And I was just, in light of that, I was hoping to just get your thoughts. What do you think? How do we kind of mesh that answer with some of the other data that has been presented here today?
When you look at the data, though, if you look at the survey, a lot of them, 50% of them were on catheterization through a catheterizable channel. A small percentage were catheterizing per urethra, and around 20% were volitionally voiding. I think what I've learned from experience is that the way we close bladder exstrophy today is totally different than what we did 10 years ago. And Doug Canning mentioned all the improvements that were made because of the collaboratives. Improvements like thinking about the bladder neck, thinking about how to close the bladder neck, not just create an obstruction, but to create a normal bladder neck appearance, funneling of the bladder neck. Those are important factors that then allow us to improve. I mean, the other thing is sexual function. I think if you look at the first meeting that I went to the US-India collaborative in India, we made an observation that Dr. Grady's penises were longer than the rest of the group. And the reason they were is that every single patient that he closed, they ended up with a hypospadias. So he compromised penile length by allowing the urethra to be at the tip of the glands. And so when you look at the result, and I think we need to figure out that's some of the discussions we had this year with the India collaboratives. Do you compromise penile length? Is that important to the patient? Or is it important to them to actually have urethra at the tip of the glands with a shorter phallus? And those are questions that I think are important to ask as we move forward. I'm really intrigued with Dr. Kokal's results because I think his results are very promising.
Thank you so much. I also found it very interesting in Dr. Canning's presentation, the use of the Pena stimulator. We've not done that, and I actually think that's a pretty clever thing to do. Two questions that have come in. One, which I believe I know the answer to, so I will answer it, but please jump in if my answer is incorrect. There's a question coming in about whether any of the panelists have created a YouTube video on the closure. I believe Dr. Canning, Joe Bohr made a video of the Mybeck type of closure, which I believe is in the SPU video archive, but I could be wrong. I don't believe we have, as the PUMA collaborative, a specific YouTube video, but if anybody's interested, we have some of those cases on film. We'd be happy to share with anybody who'd be interested. And the second question, which I'll open for the panel, is there an incidence of initially continent patients that subsequently have bladder deterioration as adults? I'll speak very briefly from our perspective that Doug Hoosman, who sees a lot of these adult patients for us and has a fairly robust adult exstrophy practice, would say that yes, indeed, he does see patients that have initial good bladder dynamics that subsequently develop a neurogenic type of scenario where poorly compliant bladder, upper tract deterioration, et cetera. But I'll open that up to the panel.
I think those failures are probably a result of the type of bladder neck closure that was done in the past. I think creating an obstruction rather than a funneling of the bladder neck. And that may be the reason why you see those adults that have failed. I'd like to hear Doug's response to that.
Well, first thing is that the Pena stimulator idea is Paolo Caione's. He published that back in the 80s. And Philip Ransley reminded me of this at a recent meeting, and we reinvigorated that. So what we think is that it helps us just sort of identify the anatomy as we go. So that's the first comment. The second one, Paul, can you just state your comment again, or your question?
The bladder neck repairs that we do today are totally different than what were done in the past with the Young Beast Bladder. Could you comment the difference between the two? Right.
Well, for me anyway, it became real for me because we had a little girl who was from the Amish country who north of us who would ride her pony between May and October. And she was dry all summer long, but she was wet through the winter. And what had happened was that she would build her core strength up. We've not done a single bladder neck reconstruction at CHOP, Young D's Ledbetters, since 1992. But what happened, we realized as this girl got older, she got drier, and we had her signed up for an augmentation many different times. But the bottom line is that we try to put the bladder together the way it was designed to be, very similar to what you presented and what Peter presented and what I think John and Heather are doing now too. And we rely on core strength, physical therapy, etc., to try to get these kids closer to voiding. I know that the numbers seem small that we achieve this in, but I haven't had a single patient that wanted to cross over to a bladder neck closure and augmentation when they felt like they were voiding. And I think sometimes we do that because we want to do that, because as surgeons, we're just sort of genetically not patient people. But I think, as Peter showed beautifully, that if you wait these patients out, they can be dry. And the bladder neck reconstruction is very minimal now. We're just trying to put it back together the way that we think it was designed to be.
I've heard my name at least 4 times. So if I might say something at this point, that would be great. Look, guys, I presented a cohort of patients consecutively treated. 70% of them are dry when they go to school, which in our country is 1 year before you guys. And they have an expectation to be dry. When I see the parents, they ask me, like they ask you guys, when you fix the operation, doctor, will they be normal? And I say that if it's a boy, it's got about 80% chance of going to school in nappies and subsequently being dry at night as he gets older. It is absolutely certain that whilst the CPRE in people's hands may enhance the length of the penis, it's 1.5 centimeters or more longer if you detach it from the pubic ramus. And this is an actual measured fact that several of your colleagues came and Pibisali and colleagues came and actually measured it with a ruler, and when we were doing the procedure many years ago. So, I'll just go back and ask you, if these patients are real, if I'm telling the truth, is there any value in it? Or are we just going to spend the next 10 years talking about our different procedures and none of us changing? Because that's what I've seen in the last 20 years. And whilst I don't want to become the stroppy guy from Britain, because I think my ex-mentor had a reputation for that, Philip, these patients are there. I have a phone call the other day from a guy who's in his 3rd year at Cambridge University on a scholarship, who's decided to become a doctor. Not only a doctor, he's also decided to become a surgeon, and he wants to be a bladder X-ray surgeon, and he wants to work at Great Ormond Street. And I might just wait around until he comes. But he was continent before his older brother. And when he went to university, he started getting a little bit of cystitis. And his mother phoned me up worried. And I said, well, actually, it might be a good thing. And I said, why? I said, because that other long-awaited use of the penis is now happening. And it has been. So, these patients exist. We can talk theoretically. I've got an idea about how it works. Who's going to come and join in the party? Who's going to do this? Who am I going to train to do this? Any young surgeons out there, you come to London, you'll be really welcome. I'll teach you to do this, and you'll knock the spots off the guys in the States, maybe. It's a chance. Who's ambitious enough to do that? And who of you old guys is going to sit down in a room with a beer at some stage, hopefully soon, and say, okay, let's try something different. Let's have the courage to do something different. We have a fantastic group of surgeons here. Fantastic. And I think there's 2 opportunities or 2 alternatives if an operation isn't really doing what you want it to do, because that's all I've heard from you guys. It's the wrong surgeon. Well, that's not the case, is it? You're the best. Or it's the wrong operation.
I'm going to have to wrap it up with that. We're running out of time. I want to again thank the panel very much. I'm sorry we couldn't get to quite a bit of questions that came in. Hopefully we can write some kind of subsequent follow-up to that. I also want to take this opportunity, of course, to thank Dr. Braga again and the rest of the SPU team. especially Brittany Fiore, who's and the behind the team people who are doing an amazing job bringing this meeting live. And Dr. Kaka, I'm going to take you up on that beer. That sounds amazing right about now, even though it's only 11 o'clock here in the States. Again, thank you all and enjoy the rest of the meeting.